Welcome. Thank you for taking the time to join us today as we continue our journey on the heart of rural nursing in South Dakota. As you will notice, when you join your session, you are automatically going to be defaulted at mute. We do ask that you keep your microphone muted during the course of the presentation just to prevent any unnecessary feedback that might come through. If you have a question that you would like to ask or something that you would like to contribute, you can do so by unmuting your microphone during our Q&A periodically throughout the session. Please, if you would, keep your video on. That just helps to aid the discussions as we go through. We also want to make sure that we maintain confidentiality at all times, and that you are aware that ECHO, in order to support the ECHO movement, Project ECHO does collect participation data for the TeleECHO program. Also, if we could just, sorry, my screen is blocked a little bit, be ready to learn. There are great presentations about to happen. So continue to reduce your distractions, invite others to attend if there's anyone else that you think should be a part of this important conversation. And please feel free to share along the way. I am Stacy Villano. If we have not previously met during these conversations, I work for the Global Rural Nursing Exchange Network. The virtual is our grant program. We work as a mission to connect nurses, students, educators from around the world who share a passion for rural health and supporting nurses in their roles to better the rural health in communities worldwide. Our partnership with USD has been incredibly rewarding because it allows us to bring the experiences that nursing students are having firsthand in the clinics, working in rural underserved hospitals, to other individuals who may be doing the same thing in other regions around the world. Our hope by partnering with your university is that we can bring this to a global scale so we can encourage more students who would be interested in pursuing careers in rural, and also to encourage educators to share these opportunities to bring the rural aspect to their nursing students in the classroom. So I would love to have the opportunity to introduce you to the two presenters, as I'm sure you're familiar with both of them very well. Helene Heggie has been practicing nursing for over 35 years. She has practiced in many different clinical areas, including as a primary RN in the rural health clinic for 10 years. While working in the rural health clinic, Helene has obtained her Master's of Science in Nursing, and she has been a nurse educator at USD for the past 10 years. Katie Franson is co-presenting along with Helene, also an instructor at USD in Vermilion. She has been a nurse for 14 years and has worked in a rural health setting and continues to work PRN in Critical Access Hospital. Katie is a coordinator of the USD Nursing Lab and Simulation Experiences, and also the co-lead for the USD HRSA Grant Experience. So with that, I'm happy to turn this over to your presenters.
Great. Thank you, Stacy. This is Katie Franson talking, as Stacy had said. So we'll go to the next slide here. So we are conducting these sessions through a HRSA grant that we were awarded back in the fall of 2022. And we were awarded $1 million for 3 years. And there are two parts to this grant. One is the recruiting of the nursing profession, especially Native American students. And the second one is getting more nurses working in the rural areas. So with the recruiting side of it, our team has been visiting schools, hospitals, holding fairs, and attending events over the last couple of years. Every year, the grant specifies that we also visit the tribal nations 2 times in that year, and there are 9 tribal nations in South Dakota. And so they've been recruiting on those areas too. To meet the objective of getting more nurses out to the rural areas, we've been placing students in rural hospitals for a clinical experience. And when they go out to these experiences, they'll complete 135 clinical hours in that facility and then really try to immerse themselves in that community. Students take a survey before and after the experience, and to date, we've placed about 70 students in rural areas, and all of them have reported an increased knowledge and interest in rural health nursing. We have been able to extend the grant, so we are excited to be able to offer this opportunity for a little while longer. Next slide, please.
The next thing that we're going to discuss, because we are presenting to a global population here today, thanks to Stacy and GRNEN of giving us that capability to partner with them, that we just want to orientate everyone to where South Dakota is and the uniqueness about our rural state. So South Dakota is located about in the middle of the United States. And again, the United States is in the continent of North America. And as you can see, South Dakota is located in the Midwest, is what we call it, in the central portion of the state and towards the northern end. And so our climate here in South Dakota, we do range from warm, hot temperatures in the summer and to cold, snowy temperatures in the winter. So we do have a range and variety of climate in our state of South Dakota. This is just a map of South Dakota itself, and the X's on this map shows where our students have been located in rural access hospitals across the state of South Dakota. So a little bit about our state is on the left side of this picture, the western side of the state is a mountainous area, and it is a home to Mount Rushmore, which is very popular nationally and internationally for tourists to come see. And it is a mountain ranges and a lot of activities to do also in that region. On the eastern side of the state, it is more farmland and flat, mainly on the eastern side of the state. And then in the middle, between it all, is open ground, a lot of pasture land, a lot of some farmable and some unfarmable land in between the east and the west. So our state really does have a wide variety throughout geographically. On the population of South Dakota, just kind of will give you an idea of how rural we really are. The population of South Dakota is 919,000 people, which is smaller than many major cities in the United States. And so that population is spread throughout the state of South Dakota. And so if we would go to the western end and drive across the state to the eastern end, it would take us about 5 hours, and it's about 400 miles. So it's a wide range of land to have 900,000 people to populate it. So it really does demonstrate how rural South Dakota is. And the two major cities on the western end of the state, Rapid City, has a population of about 80,000. And on the eastern side, Sioux Falls which is the largest city, has about 210,000 people. So the cities contain 290,000 people. And so the rest of that population is spread throughout across the state. So it truly is a very rural population, and we so appreciate having these rural access hospitals located throughout the state of South Dakota so that people can have access to quality health care, which we'll be talking more about today. So today we're going to be talking about social determinants of health and healthcare access and quality. And as we've talked about in our previous sessions, based upon our topic of social determinants of health, we know that there are these 5 main categories that the CDC uses to explain social determinants of health to us. And these are the 5 main areas that are needed for quality health care and for health in our society. And so today we are going to be looking at healthcare access and quality. And so really what that means is that it's having the ability to access comprehensive and high quality healthcare to provide positive health outcomes. So you will be discussing today different barriers to that, and it might not even just be a barrier to accessing healthcare, but it's also accessing the high quality healthcare that is needed based upon what the problem is with the patient. So many times in rural areas, even though there is access to healthcare, it may not be the level of care that is needed for that problem. Next slide, please. So today in our ECHO session, which I want to remind everyone is an all teach, all learn ECHO session. So as Stacy shared, we should all have our cameras on and the ability to turn on our microphone and have discussions. This isn't a lecture. This is more, it's a discussion. And so we want to hear about the communities that you have been in, maybe it's even the communities where you are from, and challenges that occur with access to healthcare in the communities you've served or the communities that you actually do live in. So we're going to examine the various healthcare challenges faced in rural communities of South Dakota. We will have our 2 nursing students here today present to us those challenges that they faced while they were in a rural setting for this HRSA grant experience. We are also going to discuss the availability of healthcare facilities and services in South Dakota. And then we're going to analyze the impact of geographic and infrastructural challenges of our EMS services that support the health in the state of South Dakota.
Okay, so at this time, we're going to hear from our 2 students that are presenting. So if we go to the next slide. Our first presenter is Leslie. She is a 4th semester nursing student at USD. She is from San Diego, California, and moved to South Dakota 3 years ago. She did her clinical experience in Freeman, South Dakota at Freeman Regional Health Services. She'll be graduating in December and is interested in working in a rural emergency department. So Leslie, I'll hand it over to you. We'll go to the next slide.
Hi, I'm Leslie, and I had the pleasure of completing my internship at Freeman Regional in Freeman, South Dakota. Freeman is a small, quiet town in the southeastern South Dakota. Freeman Regional Health Services is a short drive from 2 interstates that cross the state, I-29 and I-90. The town of Freeman is located along US Highway 81 and is about a half-hour's drive from either interstate. Freeman is located about 70 miles west of Minnesota and South Dakota and the South Dakota border. The town is located in Hutchinson County, South Dakota, and the hospital serves residents of McCook and Turner County. According to the 2024 census, Freeman has a population of 1,305 residents. Majority of the population is white at 79.49%, with a Hispanic population of 7%, and residents of 2 or more races making up 14%. Freeman is currently declining at a rate of negative 0.46% annually, and its population has decreased by negative 1.73% since the most recent census back in 2020. The average household income in Freeman is $61,000, with a poverty rate of 17.46%. The median age in Freeman for males is 40.9, with males being 41.8 years of age and females being 37 years of age. Freeman Regional was built in September of 1952 and has had many add-on projects to include a new lab, X-ray areas, including mammograms, 2 birthing suites, currently for emergent births only, and ICU surgical suites for colonoscopies and endoscopies once a month, a 3-bay emergency room, and a prayer room. On May 1st of 2011, Freeman Regional Health Services joined with the Vera Medical Group. Some challenges that they face are limited resources and supplies, food, and medical staff. They often rely on their volunteer ambulance service to help transport patients from their community to the hospital. If patients need to go to appointments in surrounding areas, they need volunteers from the clinic who are nurses to transport them with their wheelchair modified van. Patients also have family members transport them via private vehicle to Sioux Falls if vitally stable when a bed does become available. During my time at the hospital, I saw patients with chronic illnesses like cardiac issues, respiratory distress, complications from type 2 diabetes, neurogenic bladder with chronic Foley's, patients with limited mobility and new set ascites. And I also saw a lot of patients with undiagnosed dementia that were looking for placement or a plan of care. During my time at the hospital, how we can bridge the gap would be by providing better patient education and bringing in more outreach physicians that specialize in podiatry, orthopedic, nephrology, hepatology, and oncology, dermatology, and psychology. This would help the elderly populations get seen sooner, since a lot of them depend on rides and cannot transport themselves. Farmers that live in the area would also have easier access to specialty care without having to leave work for too long, and therefore would decrease the severity of illnesses we see in the emergency department. Freeman is a resilient community and is very resourceful. I am grateful for my time that I spent there. It was an eye-opening experience. If I lived closer to Freeman Regional, I would love to work there. The staff cares deeply about their patients. What questions do you have about the community?
Leslie, oh, I'm sorry, go ahead.
That's all right. This is Heidi Waters. I thought I would ask not necessarily about the community, but about telehealth services. Is there any options for that in the Freeman Regional area there?
During my time at Freeman Regional, I did get to experience a telehealth visit. I don't know what the name of the devices that they were using, but they had an iPad and an external stethoscope that the physician would put in like AirPods in and listen as they would place it on the patient. They also had a higher definition camera that was like a third party app that was being used with the iPad that gave them a better picture of, for example, this was a wound that they were looking at on a diabetic patient's foot. So it gave them just better clarities to be able to better visualize that. I thought that was very interesting, coming from, the pandemic where we just had iPads, to seeing that they've built in more devices that are capable to give physicians a better physical assessment of the patient without actually being in the room.
Great, thank you. I was really curious if they had what type of technology services they offered, so thank you so much.
Okay, we might get some more questions after we come back to the next part, but let's go ahead to the next slide. All right, so Megan is our second presenter. Megan is a 4th semester nursing student at USD. She is from Tracy, California, and moved to South Dakota 3 years ago. She did her clinical experience in Mitchell, South Dakota at Avera Queen of Peace. She will be graduating in December and will be starting on the cardiology floor and training to be on the cardiac ICU. So Megan, I'm going to turn it over to you and we'll go to the next slide.
Yes, thank you, Katie. Like Katie discussed, my name is Megan Torres. I had the opportunity to work at Avera Queen of Peace Hospital in Mitchell, South Dakota. Mitchell is located in Davison County, which is in the southeastern side of the state, and it is also home to the world's only corn palace. Very exciting, which attracts 500,000 people per year. It is about 72 miles west of Sioux Falls and about 85 miles west of the Minnesota and South Dakota border. The James River goes right through the town, which is also what helped Mitchell gain rich agriculture when folks settled there in 1879. I-90, which goes from Seattle, Washington, all the way through Boston, Massachusetts, also goes directly through the town. It kind of splits the town in half whenever you look at it on a map. Mitchell has a population size of about 15,607 people, which actually makes it the sixth most populated city in South Dakota or town in South Dakota. They have one private college, Dakota Wesleyan University, which brings about 1,000 students to the area each year. Although Mitchell has a substantial amount of people compared to other towns in South Dakota, it also has a large aging population as well as significant poverty. As of 2023, this town had a poverty rate of 17.63% compared to the state rate of poverty of 12.3. So it's a little bit higher. Mitchell has a remarkable critical access hospital located right in their town, which is Avera Queen of Peace. Just a little bit of background on it. The Presentation Sisters established St. Joseph Hospital, which was a 35-bed facility in 1906. They merged with the Methodist Hospital and created Avera Queen of Peace in 1991. This is a critical access level 3 trauma center and emergency department. They serve the town of Mitchell as well as 14 surrounding counties. Just to put this in retrospect, the next closest medical help is 60 miles away, which is Freeman Medical Center that my classmate Leslie just talked about. And keep in mind that that's not a trauma center. So the next closest critical care that you could receive would be in Sioux Falls. And on a map, it's about 85 miles east of Avera Queen of Peace. So it's quite a ways away. This makes receiving critical care difficult for those living in rural areas such as Mitchell and Freeman. Queen of Peace has 25 beds between the 3 floors. 10 of those are on the med-surg floor, 6 are in the ICU, and 9 are on labor and delivery. Highly critical patients are usually flown or driven to Sioux Falls for complex care. Avera does offer a little bit more than Freeman. They offer bariatric oxygen therapy, infusions, labor and delivery, cancer care such as radiation and infusions. They offer rehabilitation, cardiac and pulmonary testing, diagnostic imaging, clinical lab, sleep studies, and general surgeries. Their med-surg unit cares for folks from birth all the way throughout the full lifespan. So their team is knowledgeable and equipped for neonates, pediatrics, adolescents, adults, and elderly. Avera Queen of Peace serves many of those who are traveling through South Dakota, which actually accounts for 2% of all inpatient discharges. In 2020, only 55.48% of inpatient discharges were people who were actually from Mitchell, which puts 44.52% of those served from surrounding counties or just passing through on the interstate. During my time at the hospital, the common theme that I saw was lack of health literacy, access to healthcare, access to home health, and other resources, and lack of placement availability. I mentioned that this hospital provides service to 14 other counties, which I actually found out the furthest county that they serve is 85 plus miles away, and their closest hospital access is Avera Queen of Peace, which further just shows that the lack of healthcare access is quite substantial for those living in rural South Dakota. Home health is available in Mitchell, but they are really inundated with their patient load and lack of nurses. When it comes to placement, the facilities are full and oftentimes not accepting new patients, so they have to be placed across the state. Some of my patients personally were placed in Sioux Falls, which, like we discussed, is about 72 to 80 miles east from their current home and their family. The furthest placement I had seen was in Rapid City, South Dakota, which is clear west across the state, about 277 miles from their home and their family. So you can see how that kind of creates an issue. Um, a lot of folks use the emergency room as the doctor's office because they were not able to get into a primary care provider due to insurance, cost of care, or inability to get there during office hours. So they would, visit the ED as like a last resort, basically, instead of getting preventative care. I did see lots of telehealth visits for our inpatient clientele. These specialists live miles away. And then we had also flew out quite a bit of critical care patients to receive care at higher level facilities. This experience gave me a whole new perspective on health literacy and healthcare barriers that I had never seen before, especially coming from California. Um, this helped further shape my view of compassionate care, and I personally cannot wait to bridge the gap of healthcare disparities when I'm a registered nurse in a short few months. Thank you for allowing me the opportunity to share a little bit about the town of Mitchell, South Dakota. Are there any questions in regard to this experience or about the town?
Thank you, Megan. We're actually going to come back to that in just a second. We're going to jump to our subject matter expert, Matt Rigo. He is working, so he is going to tell us what his experiences are, and then we'll come back to what our students found, just so Matt can give us his perspective before he has to go. So Matt began his EMS career as a volunteer EMT in 2002 to serve his community. He became a paramedic in 2005 to make EMS a career. He has continued to work professionally as a paramedic in the Sioux Falls area while also volunteering to serve his community. Matt took on the Freeman Ambulance Director position in 2021. So he's just, Matt, thank you for being here, and we'll just let you have the floor until you have to go.
Sorry, technical difficulties there. Can you hear me okay?
Yes.
Okay, I apologize. Yeah, so thank you for the introduction. So my understanding is, I think it's fantastic that these students went to critical access, especially coming from a bigger, from California, it sounds like, to see how rural everything is. So the biggest issue facing EMS in South Dakota right now is it's going to be the funding, because right now we operate on a volunteer basis, and the state has done a lot of studies and is showing volunteerism is very much on the decline. So most of our EMTs that help cover the ambulance, they work an additional job. So sometimes it's hard for them to get away from their job to help cover calls. It alluded to in the first presentation, the Freeman Regional, when we are called to take a patient, it takes people out of their job for a minimum of 3 hours. And so sometimes people have a hard time getting away from that because, yes, they want to help their communities, excuse me. However, they also need to maintain their livelihood. So, and then just speaking of times, our response times are not going to be what they are in an urban setting, simply because we do not have, the staff on site. Most people have to respond from home, get in an ambulance, and respond to the call. That's just the nature of the rural EMS that we face. And then, if you recall the map that was shown earlier, the further west you go in this state, the more everybody is spaced out. So people might be responding 30 plus miles to a 911 call. So it puts people very much at a medical disadvantage being so remote. Katie alluded to the fact that I became a career paramedic. I actually work for a flight program now where we go out and help serve these communities that don't have access to transport critically ill patients by ground, because most of our small EMS services are basic life support. So we can bring the tools to safely transport those patients, whether it be the ventilators or continuing vasopressors or any of that, to enable to get those patients back to a primary care center. So other than that, I don't know if there's any other questions or if Katie has anything for me.
Matt, this is Helene Heggie. I do have a question for you. So you said that you are going to communities. Do you go per helicopter? You go per fixed wing, or how do you get to these communities?
Gotcha. Yep. Our program offers both fixed wing and rotor wing. So we try to keep the rotor wing within a 150-mile radius of our base, and the fixed wings, we can actually go across the country if needed. That has happened in the past to take people to specialty centers or something along those lines. Thank you for the question.
Matt, how often do you get called out, would you say, in a normal 12-hour shift?
Are we talking at my flight position?
Yeah.
So we have 3 aircraft. So we have 3 crews on. I would say I average 2 times per shift across the year. So, and there are days that we can't fly due to weather. Today is pretty poor weather outside. But the one thing is our fixed wings are able to fly in lower weather conditions, so that does help us out that way.
And what are the majority of patients that you're going out to get that you would say picking up and bringing back to the Sioux Falls area?
Population wise, the majority of our patients are adults. As far as specific illnesses, I can't. I would say it's more medical than trauma, just without having data in front of me. But we do serve the neonatal and pediatric and obstetric population as well. And with those, we bring along specialty nurses for those specialty populations.
This is Heidi Waters. I have another question because I have worked in rural health before. Are all the locations you go to accessible with your flight? Do they all have helicopter pads? Do they all have, what they need for those transports?
Sure. Good question. Not all of them have helicopter pads, but would have a designated landing zone, whether it be an airport on the edge of town or a parking lot within the community. And with those, we do rely on the local ambulances to help transport back and forth to the emergency department.
Thank you.
Matt, this is Megan Torres. I did have a question for you.
Hello, Matt.
Hi. So you mentioned it's primary, there's a lot of volunteers and such. So what happens if there's like worst case scenario, there's no volunteers for that day, or there's not enough volunteers for that day, and you get 5 calls that are all like STEMI MIs that need to go? Like what happens in these cases?
Yeah, well, that is a worst case scenario. A lot of small communities rely on mutual aid. And being on the eastern side of South Dakota, we have a community with an ambulance 8 miles one direction, 12 miles another. I realize it's not perfect scenario. However, there are times that communities have to help each other out.
Perfect. Thank you.
All right. Any last questions before Matt jumps off here?
I just have one question for you, Matt. Looking to the future, what do you see? What changes need to be made to improve access to care in South Dakota? If you could project like in a crystal ball, would be a perfect world. How could that care improve?
From my little slice that I see, I feel like some sort of regionalization from uh, small town ambulance. I feel some sort of regionalization um, movement is going to end up happening where you have paid staff that cover a larger um, territory, if you will. However, you just know you're going to have somebody to respond.
Great. Thank you so much, Matt, for joining us today. We really appreciate you.
Thank you. Sorry, I got to jump off here, but I appreciate you guys having me.
Safe flight.
Thanks. Bye.
Okay, so we're just going to back up here a couple slides. So Megan, I apologize for cutting you off earlier. So we'll go to Megan and one slide back at this one. So Megan and Leslie are going to talk about the things that I'm sorry, one back forward, one more with those boxes. Yep. What they saw as far as the facilities they were in for healthcare access and quality. And then after that, you can have questions for Megan and Leslie on either the communities and or this topic that they're talking about here. So Megan, Leslie, I'll let you take it over.
Thank you. Yeah, so now we're just going to discuss the topic of healthcare access and quality, kind of comparing and contrasting the both of the communities, Mitchell and Freeman. The CDC definition, or the CDC does state that healthcare access and quality includes key issues like access to healthcare, access to primary care, health insurance coverage, and health literacy. They actually list healthcare access and quality as being the most important factor to social determinants of health for folks. So just kind of setting the stage for that, jumping into our first topic that we recognized in Freeman and Mitchell was lack of high acuity care. In Freeman, there are a lack of specialties such as podiatrists, respiratory therapists, cardiologists, and specialized wound care. At Freeman Regional, they are classified as a general medical facility. They offer emergency care services to help stabilize the patients so that way they can transfer them to facilities that have a higher level of care. Freeman does have surgeons that offer routine colonoscopies and endoscopies, but just once a month. For therapies, they do offer physical therapy, dry needling therapy, lymphedema therapy, pelvic floor therapy, blood flow restriction training, Parkinson's management, occupational therapy, and speech therapy. They do partner with Avera Hospice to help with end of life planning, and they help plan for the patient and their family. They are currently referring all planned births out to other facilities and will only deliver emergency births right now. They do offer basic wound care and cardiac rehab. So I think to summarize all of that, you can see that they don't offer those emergency services like Mitchell is going to offer, Mitchell being that trauma center or the level 3 trauma center. Mitchell does have more specialties such as general surgeons, respiratory therapy, family medicine, pediatrics, internal medicine, women's health, and OB/GYNs. They have a breast clinic. They offer mental health, dermatology, dialysis, which is specifically for patients who are stable and who have received dialysis before. They're very sticky about who they do dialysis on, just for the potential need for critical care. They offer pharmacy, physical therapy, occupational therapy, rehab, imaging, urology, and a clinical laboratory. As discussed, they do have that 6-bed ICU that I mentioned before, but they don't handle anything highly acute at all. If they are of a high acuity, then the patient is flown or driven to Sioux Falls via that EMS service that Matt was just talking about. To be a level 3 trauma center, the National Institute of Health states that a Level 3 trauma center provides prompt assessment, management, surgery, and stabilization for trauma patients. The key components include 24-hour access to emergency medicine physicians and availability of general surgeons. often just with that in mind, Mitchell is oftentimes only able to provide the level of care. They are able to provide the level of care needed for a majority of their patients that walk through their door, but there definitely are patients that I had even witnessed that we had to fly and transport over to a facility that has higher acuity available. So it's hit or miss there. But I'll allow Leslie to talk about the next portion.
Okay, I will be covering challenges of transporting patients to high acuity facilities. Like Matt Rigo had discussed earlier, there's lots of factors like weather being the main one that limit the effectiveness of being able to transfer out. So there is an overall challenge to transporting patients within South Dakota, whether you are in Mitchell or Freeman. In South Dakota, we face snow and ice storms as well as windstorms and tornadoes. We have hailstorms throughout the year, which also make it difficult to transport patients. Transportation by flight is common in South Dakota, but the weather makes it particularly difficult to fly, land, and keep the plane or helicopter stable while flying a critically unstable patient. When patients are discharged in Mitchell to an assisted living facility or nursing home, they put them on the city bus and they have to cover their own bus fare. Another way that Avera Queen of Peace has had patients transferred between long-term care facilities or even to Sioux Falls for continued care is by having the patient's family drive them. These patients are stable and there is a lack of transportation availability for patients to get their continued care. Oftentimes there's a bed for the patient in Sioux Falls, so they have to get there within a certain time frame, but EMS services are not available to transport them due to their call demand. They are at risk of losing placement, so their family will drive them. In Freeman, there's a volunteer ambulance service and fire department. The ambulance service is who transports. This means you are either relying on people who volunteer their time or have additional health resources and transport them to and from Freeman Regional. Moving on to our next point, which is the lack of insurance coverage and higher healthcare costs. So let's see. A lot of folks in rural communities are self-employed, which puts their availability, sorry, I'm having a hard time saying that word today, of health insurance coverage at risk. They are able to buy health insurance through the marketplace, or they can have Medicaid or Medicare. A lot of folks in rural communities don't have health insurance at all. In Davidson County, which is Mitchell, 16.7% of people were enrolled in Medicaid in 2023. And in Hutchinson County, which is Freeman, 11% were enrolled in Medicaid in 2023. For reference, the more populated areas such as Sioux Falls had a rate of 5.7 of people enrolled in Medicaid in 2023. As of 2022, the national uninsured rate was 18.7% compared to Davidson County, who had a rate of 19.5, and Hutchinson County, who had a rate of 21.2 of uninsured individuals. I'll be passing it back to Megan.
Yes, so thank you, Leslie. I'm going to discuss the last 2 points here that we had found in working in these communities. The next one would be the higher rates of low health literacy and health education. In Freeman, as of 2022, 14.86% of people had completed a bachelor's degree, while in Mitchell, 19.31% had completed a bachelor's degree. In South Dakota, on average, 33.3% of people had obtained a bachelor's degree. So as of 2022, so that shows that they are both lower than the state average there. These counties have a lot of folks who grew up in the area and then they end up staying where they lived and where they grew up to help their family with agricultural endeavors. Low education levels do increase the risk of poor health behaviors such as smoking, drinking, and drug misuse. With health access being less available, there are less resources for people to get treatment to quit the detrimental health behaviors. The percentage of people with obesity in Hutchinson County, which is Freeman, was 35.6% in 2021. The percentage of people in that county who binge drank was 20%. The percentage of people who smoked in that county were 16.8. In comparison to Mitchell, Davison County, that in that same year, it was for obesity, it was 40.3%. The percentage of people who binge drank was 20.1%. The percentage of people who smoked was 18%. Just in comparison, the national average of obesity in 2021 was 30.7%. So both counties are higher in that instance. The national average of people who smoked in 2021 was 11.5%, which is also lower than the two counties discussed. So in rural communities, there are, just in regard to food at this point, there are a lot of mom and pop grocery stores. Usually they don't carry lots of fresh fruit and vegetables or healthy fibrous foods and nutritious foods. We did witness a lot of various fast food options in both communities. This definitely makes it more enticing and more convenient to pick up just during your day-to-day life. There are higher rates of unemployment, lower education completion, and lower financial incomes, which increase the prevalence of smoking, drinking, and obesity, as an example. These all increase the probability of lower health outcomes. These are able to be avoided if we could increase the amount of health literacy and education. So that's definitely a goal for the future. But moving on to the next point, which is our last point, which is lack of providers in the area. So more access to mental health care has been linked to better health outcomes and increased health promoting behaviors, which would be things like not drinking, not smoking. Mitchell does offer routine mental health resources, although they are hard to get into due to the population size that they serve, being all those surrounding counties. Freeman doesn't have many options. At this point, they are only offering scheduled mental health appointments as needed, but they aren't very often. Leslie did try to look up when the next appointment was, and she couldn't see any for November on the schedule. So they are not coming anytime soon, which is not very helpful at this point. So let's see. Freeman, like I said, doesn't have routine mental health services. So any emergent mental health crises, they have to be seen in the emergency department at this point. So this puts both communities, more so Freeman, at an increased risk of mental health crises, whichever one that is. Both locations do offer primary care clinics, but they are overrun with their patient loads, which makes wait times a lot longer to get into. Oftentimes it is quicker just for folks to go to Sioux Falls for care. But again, as we discussed, lack of transportation is a barrier to them getting to Sioux Falls in general. So that puts them at a, standstill there. Even if they are able to get into a preventative care clinic, a lot of folks aren't able to do or afford the follow-up care at home. So that also puts them at an increased risk of not having good health outcomes there. Let's see. In Freeman and Mitchell, the providers in the hospital are also running the clinics during the day, as well as tending to those that are inpatient. So a lot of the providers will go see their hospital patients, their inpatient patients in the morning, and then they'll go run their clinics during the day and see their patients, and then come in the afternoon and go see and change orders or whatever in the hospital. So they are quite inundated there. In Freeman specifically, there is usually only one provider in the emergency department who is on call, and sometimes they're in the facility if they, need to be there. This is definitely an issue if there are multiple critical patients who come in at one time. There are many facets that impact rural health, and at this point, we've only scratched the surface. We do hope to see some of the gaps in rural healthcare closed to allow for better health outcomes. And we don't know exactly how to get there at this point, Leslie and I, but we hope to help. I do want to thank you guys for your time and for allowing Leslie and I to dive into the challenges that living in a rural community can bring. These communities face a lot of tough instances, but one thing that we both have learned is that these folks sure are resilient and these communities really do come together, which has been incredible to see. They definitely know how to overcome and persevere. So it was great to witness. At this point, do you guys have any questions for Leslie or I about our communities, about healthcare access or quality, any of that?
I just want to share, Megan and Leslie, I think you just presented all this information so well and really addressed some of the real factors for causing barriers to access of that quality care in rural communities. And so appreciate your passion that you share about the love of rural communities. And I hope when you go back to California, I hope you don't go back to California, you can stay and help in these rural communities. So thank you so much for your information.
Yeah, thank you for allowing us to present and do all this. It was seriously an incredible, I would do it again. We both would. We've talked about it. So it was great.
Okay, so if anybody has questions or wants to ask anything about the presentation, we'd be more than happy to answer those questions for you. You can put them in the chat or unmute to ask. All right, we'll move on to the next slide. So again, the objectives we were looking at for this presentation was to examine the various health challenges faced in rural communities of South Dakota, discuss the availability of healthcare facilities and services, and to analyze the impact of geographic and infrastructural challenges of the EMS services. Then we'll go to the last slide. And so we ask that everybody completes this survey before you leave so that we can get feedback on this presentation. And thank you for coming.
I'm going to go ahead and stop my screen share. So this way I can go ahead and grab that link and drop it in the chat for you in the event that that is an easier way. If you visit the chat, you can go ahead and see the link for the survey. It is brief, so if you would be so kind as to please take a minute of your time to complete that. It just helps us prepare for future presentations, and it goes a long way in us receiving that feedback. So thank you so much. Have a good day, everyone. Take care.